Thank you, Anirudh. It is my pleasure and honor to introduce to you Dr. Chris Ellis from Vanderbilt University. He's the director of cardiac electrophysiology lab at Vanderbilt. Dr. Ellis joined the faculty at Vanderbilt University in 2009 after completing his cardiac electrophysiology fellowship at the University of Michigan. He has developed expertise in hybrid surgical AFib ablation, laser lead extraction, as well as percutaneous left atrial appendage closure. Vanderbilt has been a pivotal site for the hybrid deep AF trial and the ongoing Lariat Amaze Trial and the Amulet versus Watchman Device trial as well. The Vanderbilt left atrial appendage registry has treated and enrolled over 250 percutaneous left atrial appendage closure patients using a variety of methods. He recently published in the Sentinel left atrial appendage closure efficacy outcome data on the AtriClip placed by the thoracoscopic technique in Journal of American College of Cardiology. He will be discussing the evolving, exciting field and data behind this new field dubbed left atrial appendageology. Dr. Ellis, please welcome to the stage.
They say you need, 10,000, you're going to learn 10,000 new words in med school. So you learned 2 new ones today, bendopnea and left atrial appendageology. I don't know if that's really a word, but that's 2. Okay, great. So I'm going to discuss a little bit, building on what we talked about last year about the left atrial appendage and the role of therapies targeting the appendage in AFib-related embolic stroke. These are my disclosures. As you can see, the ongoing dilemma about stroke prevention in AFib. This poor rodent is dying and exsanguinating in the ER, but luckily he was on Coumadin, because if he was on one of the new drugs, it would have been worse. No. If you're going to bleed, it's a problem. So left atrial appendageology, this concept comes from what we consider now to be the most lethal appendage in your body. Everyone in the room here has a left atrial appendage, unless you've had surgery or something where they've cut it off. Your appendage has a variety of shapes and sizes and may actually be a predictor of your particular risk for stroke over a lifetime. We're going to talk a little about the role of the appendage, what the physiologic role is, difficulties with stroke prevention prediction, what happens if you remove the appendage, and various methods that we can occlude the LAA to help prevent stroke. And then we'll touch briefly on a few important clinical trials that we're working with other centers, pioneering this as a standard of care in the future. The initial concept of a left atrial appendageology really came from surgical data when Dr. Blackshear at the Mayo Clinic published in 1996 a series of patients that had died from stroke or had cardiac surgery and were found to have left atrial appendage thrombus. And what they noted is patients who did not have rheumatic heart disease or rheumatic mitral stenosis, over 90% of the time, if there was clot in the left atrial in the heart, it was isolated to the left atrial appendage, and particularly this implicated about 90% of the patients having embolic strokes and thrombus. It was almost always in the LAA. Less commonly, but still the majority of patients with rheumatic disease also had appendage clot. The appendage itself has a pretty odd anatomy, and this I really like this picture. The more I study this field, as we create this field and look at therapies for it, the bottom right-hand panel here, this is as if you were sitting inside the left atrium looking down into the left atrial appendage. And you can see it's from patient to patient, it's highly variable what the ostium or the entry into the appendage looks like. It's pretty rare that it's actually a circle. Typically it's elliptical, there may be multiple pits and crevices on it. But the point is, it's a black hole. Like you're looking into this thing and the blood goes in there and does what it does, and then it may or may not come out, but there's there's really nothing good in your appendage. I think of it as a garbage disposal. Now, it does have some physiologic role, and certainly in heart failure, that the thirst reflex is partly triggered by changes in the size of the appendage. The appendage can distend and swell. It's sensitive to volume load. And it is a reservoir for the left atrium a bit that you can accommodate some higher LA pressures by dilating or stretching the left atrial appendage. As far as how it achieves this, there are granules in the tissue of the left atrial appendage that actually secrete ANP, or atrial natriuretic peptide. And so interestingly, if you chop out the left atrial appendage, patients do get volume sensitive for a while. If you ligate the left atrial appendage or tie it off inside the body and those granules release, patients can get an acute hyponatremia. They'll drop their sodium and have big fluctuations in their blood pressures for up to 72 hours. But the interesting thing is it actually tends to come back to baseline over a few days with hypertrophy of ANP granules in the right atrial appendage. This is just an abstract we had last year. It's under review at Heart Rhythm, but with acute hyponatremia following lariat, which is a suture where we tie off the appendage. So the tissue of the appendage is still in the body, but it dies and all the endocrine granules are released into the bloodstream. Patients can have up to a 5 or 6 millimole drop in their sodium level within 24 hours. So that's the physiology of it. The anatomy of the appendage, we have begun to phenotype people. So these are multiple CTs from patients I've taken care of with variable anatomies. My daughter looks at these slides when I put them up, and she's always like calling out something new. So she thought this one looked like a seahorse on the top right, which maybe that's pretty good. I've seen a swan lately, hot dogs, but we generally break these down into chicken wing or non-chicken wing shaped appendage. And what's interesting is if you have a non-chicken wing shaped appendage, it turns out your stroke risk is considerably higher than patients who have a chicken wing appendage. And I'm in the process right now of looking over, for the last 3 years, everyone who's had thrombus at Vanderbilt's echo lab. And I have found 1.5 patients out of 200 that had a thrombus in the chicken wing. There's something about the shape that helps ejection of blood, and the appendage velocities are higher in chicken wings than non-chicken wings. So it's not in guidelines for stroke prevention, but certainly something I consider in borderline candidates for anticoagulation is what's the shape of their appendage. These are some examples of more of a schematic of things outside the appendage can still potentially lead to embolic stroke, even if we remove your appendage. In this scenario, you can see multiple little divots or pits in the wall of the Coumadin ridge, which runs between the appendage and the left superior or left upper pulmonary vein. This picture here shows a autopsy photo where you can see how many tuberculi there are from pectinate muscle in the appendage, and each of these can form a little crypt where a thrombus could initiate. So certainly the shape of the appendage, the ejection of blood from the appendage will predict your risk for stroke over a lifetime. In patients with a really low ejection velocity, they're more likely to have a non-chicken wing shape appendage. And this linearly declines with age. So the fact in your CHADS-2 and CHADS-2 VASC scores that one of the higher score items is your age, you get two points in the CHADS-2 VASC, it's probably related to the fact that strokes go up as people get older because their appendage stops ejecting blood. And of course, at some point, all of our appendages have a velocity of 0. Now, in the CHADS-2 VASC, the other part of this, there's nothing about whether you've had a clot in there before. And as we evolve and look at alternate therapies to anticoagulation, one of the things that you have to critique prior trials on and guidelines for anticoagulation is they absolutely do not take into account if you, let's say we're on a novel drug or on Coumadin, and you still develop thrombus in your left atrial appendage, it's not on the score, it doesn't matter. It doesn't increase your risk, but that's the patient that's at the highest risk. So we're keenly on the lookout for if you have had thrombus before in the appendage, it may be a very high predictor of future risk. The other thing that's not in CHADS-2 or CHADS-2 VAS score, and it's something that I was taught in medical school, it doesn't matter if you have paroxysmal AFib or permanent AFib or intermittent AFib. You basically get about a 3 to 5-fold increase in your stroke risk compared to the general population, and we treat everybody the same. One of the cool things I think from the large randomized trials with novel oral anticoagulation that we can now tell for sure, we can demystify or debunk that theory, and I think it has perpetuated through the AFFIRM trial and somehow become dogma that it doesn't matter if you go into chronic AFib. Well, even if you're on an anticoagulant, permanent AFib demonstrates a 2-fold higher stroke rate over time than if you are in paroxysmal AFib, and that's in 17,000 patients in a randomized trial. That actually was demonstrated both with the apixaban studies and the edoxaban studies. So if you get an AFib patient, you're at risk for stroke. We're going to put you on a blood thinner. Okay, the problem is you're probably not going to stay on a blood thinner. So about 3% of people will have some bleeding event annually. In the course of the clinical trials with the novel drugs, about 25 or 30% of patients discontinued their anticoagulant within 2 years. That's including, the nurse or the following physician calling the patient, reminding them to take their drug, giving them free drug, doing everything we can to improve their compliance with therapy. You still see a linear decline, and it just continues over time. There's another study I don't have a slide up on, but with Coumadin in the past that I read, where over 10 years, so if you're on Coumadin, 5% of patients remain on Coumadin 10 years after the drug is prescribed. So you're not really treating, especially if you have a young patient who has high stroke risk, you're already thinking about alternatives which previously didn't exist, and that we'll discuss further in the next few slides. Of course, this is the big fear of intracranial hemorrhage from any of the anticoagulant, also a deterrent to patients staying on or being prescribed the drugs. And in the Pinnacle registry, what you see in the yellow box is that patients with a CHADS-2 VASC of 3 or higher, like right now, 193,000 patients were in this study. 50% of them are not on anticoagulation. So there's a huge population of AF patients at risk that are not getting stroke prophylaxis. And I would argue that that's probably the most important part of AFib management, is preventing embolic stroke. So why don't we just send everybody to heart surgeon and we'll chop out all their appendages? It doesn't work that way. And it doesn't seem to work. So the only randomized trials of surgical closure which have been done demonstrate about a 45% efficacy of closure with sutures and maybe a 70% efficacy using a staple gun, which is really designed to staple bowel and not a high pressure vascular structure like the left atrial appendage. There is a very important clinical trial going on, and I'm going to be speaking on an update about this in San Francisco tomorrow, actually, where they have, it's called LAUS 3, and Rich Whitlock is the main investigator in Canada. They have about 3/4 of the trial done. They're taking 4,700 patients undergoing heart surgery and randomizing them to cutting out their left atrial appendage or not. And the weird thing is they didn't put anticoagulation management in there at all. So fundamentally, what it's going to prove or disprove is that you can live without a left atrial appendage, and if you don't have one, maybe you live longer and maybe you have fewer strokes. gonna skip that one. There's other methods to closing the appendage surgically which are coming along. Invagination is a kind of a bizarre technique. You can see they pull the appendage up and then sew it down with a purse string, but they're not really removing the appendage. I mean, the images look good, but this is the problem. I mean, now that I'm studying this and keenly on the lookout, I get patients like every week that have had, quote, prior heart surgery, appendage closed on the operative report. The physicians are treating the patient and behaving like they don't have an appendage. And then I get a CT angio, and I find all kinds of interesting things. Here's a nice incomplete closed neck. That's left a horribly difficult stump to close. Here's another one. This one, there's like suture sort of half across the ostium of the appendage. I was able to squeeze a tiny device in there and plug it, but your incomplete surgical closure is a problem. It's actually increasing your risk for stroke. So if we look at patients who have had closure of the appendage but left the patient with an incomplete neck, their risk for stroke is increased over patients that we either didn't do anything to the appendage with or completely removed it and it looks good on CT. Not having complete closure is associated with late events as well, and I think this is because people are erroneously stopping anticoagulation because the surgeon said they closed the appendage. There's another way to close the appendage, which would be to actually clip the appendage off with a device that can be placed through thoracoscopic ports like this. Of course, if there are any astute observers in the room, those are scope ports in the right chest. It just gives me a diagram. The appendage is on the left, so if you're going to do a standalone clip, these ports would be in the left thorax. Here's an example of a left atrial appendage being placed inside a clip. And you can see we have, with direct visualization, of course, you can see coronary sinus, left circumflex, but that's one lobe of the appendage. But we got to tease this second lobe out or we're going to get an incomplete closure and not do this patient any good. There you go. So we'll pull it in, and then you can actually grab the appendage and kind of tug on it just a little bit. It's a delicate item. You don't want to rip at the appendage, but you give it a little tension so you can pull the clip right down onto the left atrium and get a good closure. That can also be done through an open chest procedure when patients are on bypass. This study in 2011 with patients undergoing bypass showed about a 95 or 96% closure rate with the clip, so much better than a staple or a suture gun. We took patients that we had done LAA closure with thoracoscopic method and did a 3D CT angiography, had a chest radiology group independently evaluate them and tell us whether there was any leak and what the position of the clip is and where was it in relation to the circumflex. You can see most of the patients, there's a nice clean line where the clip has chopped the appendage off and left minimal smooth stump behind. We found about a 96% efficacy with that closure method, so it seemed to work well. And in our cohort of patients who had this done, if you looked at their predicted stroke risk by Chad's 2-VASC score, had about a 64% relative risk reduction, so 0.6% stroke rate per year compared to an estimated rate of 2.7%. And that's off anticoagulation. So that's kind of a background of where we might start to think about closing the appendage, but you know, these are methods that are not going to be widely available or generalizable as a treatment to prevent stroke. But this might be. In Europe, this device has been out for quite a while, but we ran clinical trials on a device called the Watchman Device, which is basically a plug. So as you remember looking down into the left atrial appendage or looking into this black hole, we're basically just trying to plug the hole with this device called the Watchman. In the clinical trial that got FDA approved eventually, they took almost 1,000 patients, randomized them 2-to-1 to Watchman or Coumadin, and you know, if you did a body count at 5 years, Watchman wins by a pretty good margin. And probably because of a reduction in hemorrhagic stroke, the efficacy for ischemic stroke protection was pretty similar. I'll go over that in a sec. This is basically the concept of where the device would go. It would plug the ostium of the left atrial appendage. These are multiple views of it on TEE. All-cause stroke was basically non-inferior between Coumadin and Watchman, but the major reduction in hemorrhagic stroke and unexplained death in the Watchman group favors the device, and there was a second clinical trial called the Prevail trial, and then 2 subsequent registries that have at least confirmed it is a reasonable stroke protection therapy. The Prevail trial threw a monkey wrench in the FDA analysis, which is why if you look back, it took them 3 panels and multiple reviews before they finally agreed to approve it. But it was approved 2 years ago, and we've done, I think, 140 or 150 Watchmen. I'm actually surprised every day how the device is just not on the radar for a huge number of cardiologists. Like, they're just not aware of it, or really haven't began to think about it in their population of patients with AFib. The clinical trial characteristics, people who got a device in the trial, pretty much your normal high-risk patients, mostly CHADS 2 VASC 3 or higher. And that's what Medicare has agreed to cover. This is the relative risk reduction for stroke that you are expecting from the device, which is around the same relative risk reduction that you get with apixaban, rivaroxaban, edoxaban, or Coumadin. So pretty comparable reduction because it eliminates the vast majority of AFib-related embolic strokes. Now, the stroke rate in these clinical trials is not 0. There's still people that have strokes. Why? I've had patients we've closed, then it turned out they had severe posterior cerebral circulation disease and had, basically lacunar infarcts from hypertensive strokes. People can fall and bleed. It has nothing to do with embolism from the left atrial appendage. Of course, you can have paradoxical emboli through a PFO. One concern with these, of course, you're doing a transeptal punctures. If you leave a big hole after putting in the device and then they have a paradoxical embolism, that kind of defeats the purpose. But the holes close. It just takes a few weeks. Selecting patients, they basically suggest, this is FDA labeling for it, CHADS 2 VASC 2 or higher, but Medicare won't cover it unless you're 3 or higher. Suitable for anticoagulation because they recommend 45 days of Coumadin after you put the device in, and then has an appropriate rationale to seek an alternative. And that's becoming a bigger and bigger and bigger pool of patients. And when you really think about it, if 50% of AFib patients at risk are not on an anticoagulant at all, then they are candidates for this device. The safety of implant is a key point to making it generalizable, because if you're going to do a prophylactic therapy that delivers risk, it has to be low risk. And it is low risk, and it's getting lower. Every trial that comes out, the risk of the procedure has been reduced. The early trials had some issues where just not having a lot of transeptal access experience and being able to manage sheaths and understanding hemodynamics, like air emboli occurred in a few patients early in the trial, which is what kind of gave you this high early, and those were actually counted against the device as ischemic strokes, and it still ended up superior to Coumadin in terms of mortality. So in our experience, the real complication risk using ultrasound for vascular access, doing these on systemic anticoagulation, and running the patients for the 45 days really is about 1%. Of course, if you push a device through the left atrial appendage, that's not good either. So this is one of the things about the procedural part of it is the device is pretty big and you need some room to stick it down in that hole. The shallower depth the hole, the more challenging the implant. But even with that, the clinical studies have demonstrated a 95 to 98% implant success rate. Let's skip that one. This is a device that we're testing head-to-head against Watchman in a clinical trial with the primary endpoint being stroke. And so it's going to compare patients 1-to-1. Watchman, or this is called Amulet, is a slightly different concept, but the device can be placed way more closely to the ostium, and you don't have to worry about what's sort of in the back end of the appendage as much. And it has kind of a two-layer closure. There's a lobe that sticks here where the Watchman normally would be, and then a large disc that really covers the whole space from the pulmonary vein down to the mitral annulus. I'm going to skip that one. Here's an example. Looking down into that black hole I've showed you before about looking into the left atrial appendage, and here it is with the disc covering that whole space very nicely on a 3D TE. Now, this is a patient that I'm not going to mess with trying to close their left atrial appendage today. She's got a huge LAA thrombus. Yeah, if the videos don't play, don't worry about it. This patient has thrombus, but it's sort of halfway down into the appendage. Sort of the distal half of the LAA here is thrombosed, and a lot of spontaneous echo contrast. And she was a patient we were trying to do an AFib ablation on, but it was like we just kept having problems with clot. Fortunately, I was able to get, after our experience and outcomes been good enough, I tricked the company into letting me put the patient in our clinical trial for closing, and she actually got randomized to amulet, which was perfect. So here I'm starting to open up the amulet lobe with all the thrombus below the device, and then sealing it off. You'd see that this would open up like a disc, but then it covers, and I basically have closed everything below the device, including active LAA clot intraoperatively, and she's done wonderfully. She came back for her ablation, and now she's in normal rhythm too. So the observational data, at least the registries that have been published so far, demonstrate about a 60% relative risk reduction in stroke. Again, that's going to be assumed to be comparable to the other device, but we have to prove that in the randomized trial. My feeling is on it, probably the safety of implant is a little higher, and the efficacy of closure may be a little bit higher with the new device, but we have a long way to go before we prove that. Renal failure patients are good candidates for LAA closure because they're high risk for bleeding. Our transplant nephrologists have really actually latched onto this because they hate NOACs, and they have to keep biopsying patients' kidneys and interrupting anticoagulation. So we've actually closed a fair number of those patients and gotten them off blood thinners, and they're quite appreciative. And they've done well. These patients do, of course, similar to defibrillator therapies and other preventive therapies, have a lot of chances to have non-AF related embolic stroke, so they may not end up with pure stroke protection of all causes, but at least the reason you put them on the blood thinner, we can potentially provide an alternative to that. The last component of this talk was to talk a little about the role of the appendage in actually triggering AFib, and some work we're doing on targeting that as a treatment to help restore normal rhythm. It turns out that I told you about the ANP granules. There's also some heavy autonomic innervation around the ridge of the left atrial appendage, and some of that will lead to spontaneous firing, basically acting like a secondary pacemaker site or an agitator to the rhythm with a lot of extra beats or ectopic beats coming from the appendage. And sometimes you can actually see this initiate atrial fibrillation, and if you immediately clip or tie off the appendage, the AFib will stop. There is a clinical study done that Dr. Natali did on a series of patients getting an ablation called the BELIEF trial. It was recently published in JACC and demonstrated about a 30% improvement in the chances of you staying in normal rhythm if they did an ablation around the base of the left atrial appendage in addition to the usual targets for AFib therapy. I'm a little bit skeptical that I would ever want to ablate around the left atrial appendage alone, because once you electrically isolate the left atrial appendage, of course, the ejection velocity essentially goes to zero. So I have picked up a few patients that were in that trial who have an akinetic appendage, and at least my teaching from when I was a fellow and we did a lot of ablation in Michigan, the goal was never to isolate the left atrial appendage. And if you did, we kind of felt like that obligated the patient to lifelong anticoagulation regardless of their rhythm. So a different approach to this is to actually tie off the appendage with a suture that's like a noose. It's like we call a lasso, or it's called lariat. And it can be inserted into the pericardial sac, actually go on like over the appendage and tie it off at the neck. You get acute ischemic necrosis of the appendage. It basically dies, but it electrically isolates the appendage and occludes it. So may give us the rhythm protection benefit, but also avoid that thing we don't like, which is obligating the patient to blood thinner forever. Early studies we did on series of these, this is a non-FDA approved device, but we had done many patients who were contraindicated to anticoagulation and had pacemakers or defibrillators in place. And just by looking at their diagnostics on the device, we saw about a 25-30% reduction in total AF burden at 1 year, only by ligating off their appendage. So that formed the basis of this called the Amaze Trial, which we're in the process of doing, but maybe about halfway done, where we're taking patients 2-to-1 who have persistent AFib. So they're more difficult to treat patients who, you wouldn't necessarily expect a pulmonary vein isolation or your basic basic AFib ablation to fix. 2/3 of them, we're going to ligate the left atrial appendage and then do their ablation. And the other third would get just a catheter ablation only. Of course, the endpoint would be AFib recurrence at 1 year, and this is going along very nicely. Of course, your previous mentor, Dr. Laccaretti, is one of our main co-investigators on that as well. Now, nothing is perfect. We know that. Anticoagulation comes with high cost of drug, high discontinuation rate, adverse events, and you have to take a medicine forever. Putting in a device, we don't know everything about this. It's only been in maybe 5 or 10 years. Some of these, if you don't seal it off 100%, you may get a leak around the side of the device. A lot of debate about whether that matters or not. With the lariat, if it doesn't completely seal it, you may get a little pinhole leak of blood up the middle. Probably not an issue, but we need more data, so that's why the clinical trials are really important. And these are obviously, there's other procedural things that can go wrong, and they may have nothing to do with the device. And I've seen this a couple of times, and it just hurts. But one of our patients had a major hematoma in his throat from the TEE probe, and ended up having problems with that for about a month. Eventually did fine, and his appendage was closed with a Watchman, so he never had to be on anticoagulation. But there's anesthesia issues, and then the TEE. So coordinating that, making this a frontline therapy for that 1.5 million patients, we got a ways to go. It would be nice to get TEE out of the equation, but honestly, it's my feeling is it's essential to get a successful implant. Some people do this with intracardiac echo, or you can try to do it with fluoroscopy only, but it can be really difficult to tell on just an angiogram if you're in the right region to close at the ostium of the appendage, and whether you have a leak, because contrast will go through these devices because they're porous until they endothelialize. So you put a device in and shoot contrast at it, it goes right through it. Sometimes it's hard to tell if there's a leak around the device. So with that, I'll wrap up. I'm happy to entertain any questions about this. Most of the patients that we evaluate, we'll do a pre-procedure TEE or CT angiography if their renal function will allow. I've moved more towards doing CT because they just seem a lot more accurate, and we can play with it offline a lot more to make sure that we size the device properly. Thank you.
Thank you, Chris, for such an excellent review.
Thank you, Cass.
I really enjoyed your talk, and I want to congratulate you on this new device which you're doing it. In fact, two of my patients, you have placed Watchman Device. They are doing excellent. They're enjoying well without any Coumadin or any such agents.
Good.
So that was really good. So I have two questions for you.
Sure.
The first one is the incidence of stroke is low in patients with paroxysmal atrial fibrillation compared to those who have chronic AFib in such a large number of patients. So what is your thought about aspirin alone for patients who are having rare episodes of AFib, especially elderly people who have a risk of fall?
Sure.
What do you think about that?
That's there's a complex discussion about that. So first is that aspirin is not a great stroke prevention therapy for AF, and it's not entirely benign. There is a study called ASAP-2, which is for contraindicated patients, where they're going to look at aspirin only versus a Watchman only, like no anticoagulation at all in either group. So that may inform us a little bit. The idea of when you're in AFib is when you're at risk for stroke has been disproven, I think, pretty close. I mean, the HRS sessions have had a lot of interesting studies where patients with continuous heart monitors in place, the time they have a stroke is not really associated with the time they went in and out of AFib. It could be a week before, a month later. It's a strange thing, and so there's a moving target of explaining you getting a clot in the appendage and having a stroke and AFib. They may not be like linked, which is an interesting thought that maybe we're missing the point. Patients at risk for stroke happen to develop AFib. It may not be the AFib that causes it. Now, flip that on its head and go, I just showed you that it matters if you go into permanent AFib. So I'm not sure that that we can answer that definitively, but at least guiding therapy by when the patient goes in and out of AFib, I tend to avoid that. Some people are looking at studies using loop recorders and saying, the patient will send a transmission, and then if they're out of rhythm, they start taking a NOAC. And see how that goes for stroke prevention, sort of intermittent therapy. My other concern with that, of course, is there is data that if you interrupt the NOACs, at least for a few days, you're at a higher risk for embolic events and thrombus. So, I think anticoagulation, stroke prevention, I think is all or none. Either you need stroke prevention therapy or you don't. I don't think it changes from day to day.
That's very good. So second question is patients with coronary artery disease. Say, for example, last week I had a patient who had an anterior wall MI, required drug-eluting stent. He's a young guy. I really didn't want him to get a bare metal stent. And he was in AFib with decompensated heart failure. So we cardioverted him a few days later. So here the question comes with new data from Pegasus study about Brilinta being superior comparing to some of the other antiplatelet agents. So if the patient is on aspirin and Brilinta, adding novel agent or just adding Coumadin is such a tough decision, the way I see. But we had no choice on this case, and we ended up putting him on Coumadin, and he wanted to go home, so we gave Levodopa shot, plus aspirin, plus Brilinta. So,
How did he do? He hasn't bled yet? Oh, yeah. That's definitely a population of folks that you could entertain closing because there's decent data that you'd only need dual antiplatelet therapy. Like the 45 days of Coumadin after an implant is mainly based on the clinical trial, how they set it up. It's not absolutely necessary. long term, if that's somebody who needs to stay on Brilinta or Effient or one of these, I understand they certainly increase the bleed risk. It's a patient that would be a reasonable candidate to at least consider that. The procedure is not bad on the patient, like I said, apart from the anesthesia and the TE part. Most of these we're doing in 30 minutes or less. So we can get them in and out of the table quickly. It's good. Yep, good question.
I have one question, Dr. Ellis.
Sure.
So I think a lot of studies so far have focused on the safety and outcomes and proving non-inferiority of these devices compared to warfarin. But I think we are still at a loss where we don't know who is the right candidate, like who to refer for sure for these appendage closures. I know patient preference matters in terms of avoiding medication, but if I had a patient with, say, upper GI bleed, who we sent to upper GI endoscopy and they found a reversible cause and they treated it, would it be okay to re-challenge them, or do you think they should just be considered for?
Yeah, that's clinical medicine. You're going to have to make that a bit on a patient-to-patient basis. I would say, for the most part, if your CHADS2 VASC is 3 or higher, and your HAS-BLED score is 3 or higher, then regardless of when the bleed happened, or you're at least somebody that it would be a reasonable consideration for. I've gone back and forth on this. Most of the patients we did initially were elderly patients that were fragile and contraindicated to anticoagulation. But when you look at 10-year adherence to an anticoagulant and the accumulated risk of exposure to a younger patient, it may be that the younger patient with AFib, diabetes, hypertension would be a better candidate than someone late in their life when, fall risk and other things are being more of a consideration. Because I think the only thing about that makes me a little nervous is I have seen 1 or 2 folks where their appendage got larger, after we had implanted the device. And if there's any leak and you have chronic high left atrial pressure and the appendage opens back up, now you can have large leaks around a device. So we're really trying to put big devices in now and seal that thing so tight so that it totally endothelial. Then once it's thrombosed underneath, I don't think it would reopen, but things like long-term consideration should be. But patient to patient, absolutely, re-challenging people with a NOAC is very reasonable, especially given a lot of the NOACs have better bleeding profiles than warfarin, and now have, at least some of them have reversible characteristics with an antidote. That's been a problem, though, with rivaroxaban, and tend to see a lot of bleeds with that.
That was a really good talk, Dr. Ellis. Sure. And I'm really scared now about my appendage. I've been praying to God I don't have the chicken type appendage. Could you just
There's only about 25% of people have a chicken wing. Yeah.
So one question I had was, is there a way on TE you can tell whether it's a chicken wing type or not?
Yeah, so that's actually a really important part of this. So as you move this out and realize there's so many more potential candidates, getting cardiology practices actually trained on doing the imaging is important, because the critical view is a 135-degree angle view on TEE, and it's not one that you typically get. The easiest view to see the appendage on is 45 degrees, and it always looks the same. Everything looks like a windsock on a 45-degree view, but you have to get to the wide angle to be able to see the distal part of the LAA and when it rolls up towards the pulmonary artery. So you can phenotype it on a TE. It's a little harder to do, but getting trained on how to image pre and post Watchman would be, it's a great thing to add to your practice, because I think going forward, I'm assuming you guys eventually will be doing these as well. Getting trained on the imaging is really important. It makes a huge difference. If you have bad pictures going in, and you pick the wrong size device or something, it may cause a problem. So, but you can see it. It's just it's a little harder because you got to get that wide angle. Everything looks like a windsock in the usual view that people look at when they are doing like a cardioversion or rule out clot. Yeah.
So 135 degrees.
Yeah.
Could you summarize for our audience in one line who are referred to you or tertiary care center for left atrial appendage closure devices?
Probably the easiest thing is just to ask yourself when you're seeing a patient who has AFib and a high CHAD score and they're not on a blood thinner, why? And then if you have a clear why, that's someone you could think about referring, right? The alternative method is, like I said, use the bleeding risk profile score, and patients at higher bleed risk should be at least considered. Start thinking about it. It's an alternative. It's rational. I mean, I think there's actually cost-effective data now that show after 5 years post-closure of the LAA, your total cost of care for AF stroke protection is less than warfarin or NOAC from implanting a device.
Thank you so much for your wonderful talk. I am a hospitalist over here, and I had a quick question that does these devices, they work better in any particular form of AFib? Like you mentioned before that in permanent AFib there was more risk of having stroke, so like does it work better in that as compared to paroxysmal or not?
I don't know if the Protect AF data, if they have a sub-analysis for the classification of AFib that the patients who got Watchman had. I don't think so. Patients occasionally can get thrombus on top of the device, because it's a foreign object, and the rate of that may be 2-3%. The people that are more likely to get that are older with renal failure and chronic AFib and a really large atrium. So, in that scenario, you might say the device doesn't work quite as well, but I don't really know. We don't have outcomes for that. In the trial, they didn't specify that you had to have, in like the Protect AF study for Watchman, it was just a diagnosis of AFib, not based on persistent or paroxysmal.
Thank you.
One last question.
Sure.
So as you mentioned, if we had to start a appendage program, say, what are your tips and advice for us for a?
Yeah, well, I mean, a big one. So because it's a TEE guided procedure, I've gone from day one to having my cardiac anesthesiologist do the TEE. So they are the intraoperative anesthesia and imaging person. Well, I do proctor and help other sites get started on this procedure, and what I have noticed is centers where they have to call in an echo specialist or a cardiologist, they're way less efficient. And it's just, the more people involved, I think, the less efficient the procedure will be. And it should be ideally quick. So if you're taking it and dragging it out because there's the patient's waiting on the table 45 minutes for someone else to come in and do the TE, especially if you're transeptal, anticoagulated, I think the adverse event rate would go up the longer the procedure is going. So one suggestion is, engage a relationship with cardiac anesthesia. They do TEs, intra-op for the cardiac surgery cases. They're actually very skilled with it, but that would be one thing. And then you really need to get out and educate the medical community about it. I mean, it's taken a while to build what we have done at Vanderbilt, and it's been because I'm talking to the neurology grand rounds, nephrology grand rounds, talking to the Coumadin clinic. There's a lot of places to interface with decisions about anticoagulation in AFib patients. It's not just out of your own practice. You can get started that way, but it's difficult to maintain it because you probably don't have an infinite number of AFib patients.
Thank you so much.
You're
That
welcome.
was a great talk, and we can move on.
Yeah, we'll give Dr. Ellis a big round of
All right.
applause. Thank you.